The next few slides are just a little bit about the background to how accredited pharmacists can support medication use in these environments. So what the Pompita Group has done is that they're aiming to raise awareness and improve access to medication reviews. And so what they've done is they developed a flow diagram, and this flow diagram may actually be useful to Kerry and Nicole as they're working towards developing a model in your area. So it's a process by which stakeholders in the disability sector can trigger a medication review. This is the original model that was developed by Pompita in Adelaide. And this was originally funded by SAM. So the payment for the accredited pharmacist to conduct this medication consult was the pharmacists were originally remunerated by SAM and her I Can Jump puddles. So it's certainly initially the medication consult, and that can be triggered. I'll just run through this flow diagram. So initiated by family, carer, allied health, the community pharmacy, a case manager, or of course the patient themselves. So all of these people can identify the need for some pharmacist input initially. So there may be a need for a rapid response, but if there's no need, so there may be some outstanding adverse effect or a really important drug interaction that maybe the community pharmacy has noticed, or the patient reports a new adverse effect. So in which case there may be a need for a rapid response. So if that's not the case, then the pharmacist may fit the criteria for an HMR. So when an initial consult occurs, so a pharmacist will look at the medication list and look at the medications the patient client is using. And so one of the most important things is to do a medication reconciliation. So that's matching up what's on the medication list and what the patient is actually taking. So that information can be provided to the GP, the patient, allied health, carers. And if then there is identified a need for a more comprehensive medication review, and that's the home medicines review that I mentioned earlier, that medication consult can be used to suggest to the GP or to one of those other medical specialists I mentioned earlier, so a paediatrician, neurologist, psychiatrist, that can trigger a referral. So also, as you can see with that big blue arrow there, initially it may well be identified by the pharmacist that the patient can automatically qualify for referral for an HMR. So if the referral after this reconciliation does land with the GP, then the GP will review that request for a referral, and it's the GP's role to consider the clinical need for the HMR. And I might just add that general practitioners only, not the medical specialists, so GPs only, are remunerated under the MBS item number 900 for an HMR. And the remuneration for a GP, approximately $160. That does change slightly from time to time. So the MBS item 900 has a lot of detail in the notes section about what's required by the GP. So when the the GP does provide the referral. That referral goes to either an accredited pharmacist, such as myself, or it can be referred to a community pharmacy of the patient's choice. So if the referral goes to a community pharmacy, it's then the role of that community pharmacy to identify an accredited pharmacist to conduct the review. So it can either be an accredited pharmacist on the community pharmacy staff, or it can be an external community pharmacist. So that's the way I work with my local community pharmacy. So I have a full-time job. I only conduct medication reviews as required, and I get referrals from my local community pharmacy, and that works very well for both of us. So after the referral arrives at the accredited pharmacist then organises an interview, and that interview must be face-to-face unless there are exceptional reasons why that doesn't occur. We did have telehealth during COVID, which supported the ongoing HMRs, but that the telehealth service was ended at the end of December 2022. So the accredited pharmacist conducts the HMR with the patient and their carers, and there may be other allied health professionals taking part in that interview too. Then the accredited pharmacist writes their report. It's generally a comprehensive report. It has a medication focus, but it's designed to provide suggestions to the referrer as to how to appropriately manage medicines for that particular patient. It also suggests, it can suggest non-pharmacological activities, and it can also provide the GP with information about deprescribing, also about monitoring. So when medication's changed, it may be that monitoring on response to any particular change is required in a week or 2 weeks or 4 weeks. So it's up to the GP then to facilitate that monitoring. So once the GP has received the report and reviews it, he or she then must develop, according to the MBS rules, a medication management plan. And that medication management plan is written in conjunction with the patient, their carer, and perhaps other allied health. And so then that medication plan is distributed to everyone that's involved in the patient's care. And also that a medication management plan goes back to the accredited pharmacist and to the community pharmacy, so everyone involved in that patient's care is on the same page and can work collaboratively for the benefit of that particular patient. And of course, what we're all as pharmacists wanting to do is to advance quality use of medicines and minimise medication misadventure.